So if we can just move on, that'd be great. So you will be familiar with our vision and our purpose, why we exist, and the impact we have. I'll just state the vision so everyone gets it. Everyone receives safe, effective, and compassionate care. And I think when we get into the details and the intricacies of the assessment framework, it's easy to get lost in the technicality of it all. But at heart, what we're trying to do as a regulator is just the same as everyone else is trying to do who works in health and social care. And I think it's really important that when we get perhaps stuck on an issue or we're not sure what to do, if we have that underlying vision that unites us all underneath what we try to do, it will help us get the best possible decisions and outcome for the frameworks. Thanks. The problems that the CQC have experienced are well documented. Reports from Penny Dash, our current chair, Sir Mike Richards, and a report, really useful report, certainly from my perspective as the Adult Social Care Chief Inspector from the Care Provider Alliance, and indeed references in a 10-year plan, show two things: both that there is an agreement that a quality regulator is really important to help safeguard the quality of services in health and social care, and crucially, from my perspective, help drive improvement. But the CQC needed to change fundamentally and do a number of things differently to restore its capability and credibility as a regulator across health and social care. The session today focuses very much on one of the key components of both Sir Mike's and Dr. Dash's review, which was around the assessment framework and how that operates, and the need for that to be refreshed and looked at again to underpin the regulation work that we do and the work that providers across health and social care do day in, day out to deliver quality care. So we will focus on that today, and it's part of a whole range of changes the CQC are making. We won't go into too much detail on all of those today because we really want to focus our time on the assessment framework. We move on. So this gives you a sense of the scale of the entity of the consultation work that we've done so far. So we had for the first stage extensive consultation in the winter, so in winter in 2025, where we had about 1,700 providers at different public-facing events and online consultations. A lot of those from adult care, as you'd expect, because that's where the majority of providers are. But what was pleasing for me is the range of providers, all the way through some of the biggest in the country to some of the smallest, and a good mix between all the different sectors that we regulate: adult care, primary and community care, mental health, and secondary care. Since then, we've done 2 in-person events so far in the next sort of range of consultation, and we'll also be making sure that after this sort of round, we'll be doing really specific work with different sectors, because one of the things that we're doing, we'll talk about that, is moving back to sector-specific assessment frameworks. And as we get into more detail and we build up our assessment frameworks, we'll want to then narrow down some of that consultation to focus on specific groups, perhaps where there's some real specialist issues that we need to look at. And a commitment from the CQC is that whilst we may only formally consult on the assessment frameworks relatively rarely, in between time we've got the chance through things like ratings, characteristics, but also guidance to make sure we can tailor it both to different perhaps subsectors, for example within adult social care, perhaps home care as an example. We can tailor it to reflect those needs, but also be really cognizant of the fact that provider services, the health and social care landscape is changing. If we did this exercise 6 years ago, we probably wouldn't have been talking about artificial intelligence. Now it's something we probably all use or talk about on a daily basis, and we need to remain nimble and agile to those changes. So the focus for absolutely is how we're going to change both the assessment of what we're doing, but also our methods for inspecting and assessing and awarding ratings, which are really important and have got a crucial interplay. If we move on, thanks. So moving on then to the work that we're going to do in June, we've got some sector-specific focus groups going on, and crucially, I think what's important in all of these, we're going to talk to people with experts by experience. So they're people that use services or support people that use services. The public, a key stakeholder for us. We know in adult care, for example, 76% of people use a CQC report to make a decision around their care. that decision might be one of the most important decisions they make in their life, either for themselves or for a loved one. So it's vital we get this right for people. And in a number of the groups that we've had already and that we're going to run in June, I found personally the real value in having people that are going to use the assessment framework as, for example, a CQC inspector, and providers that are going to be being inspected. And actually, assessment frameworks and our methodology needs to work for both of those groups. It's got to be workable. We've got to be able to use it as a regulator, and it's got to be meaningful for the people that are providing services. And underneath all of that, as a kind of coalescing force, I suppose, it's got to work for people that are using services or advocating for those people that are using services. That needs to be our kind of North Star in what we do. And I think, as I say, that's quite a helpful unifying force when we work through how we want this to be best developed. Move on, thanks. So I said there was some wider work going on in CQC for the changes and the transformation that we know we've needed to undertake, and I'll very quickly recap some of the things that we've done now. So first thing to do, from November last year, we returned to specialist teams. So what that means is, rather than having local teams that would inspect hospitals, mental health trusts, primary care and adult social care, we've gone back to sector specific teams. So it might be the TOLI's secondary and specialist services teams, or it might be my adult social care teams underneath each chief inspector. That's gone down really well with colleagues and I think providers. We know that there's huge interdependencies and links across health and social care, but each sector that we talk about is also special in its own way and specialist in its own way. And we think dedicated colleagues that can develop their specialism, their expertise, and are exposed to more providers from within that sector will deliver more informed, I think, and capable inspection teams. But also allows us as chief inspectors, and Tolly and myself are on the call today, to have a much better feel on a day-to-day basis around the quality that we're seeing in the sector. And having those teams that are specialised across the country helps us gain that insight into what's happening across the country. We've looked to really improve the work we've done to handle information of concern. We get tens of thousands of bits of information a year coming through, and we're really nearly hitting our targets on how quickly we're going to we turn those around. We triage those, as you would expect, and make sure they get answered properly, investigated, or passed on to the appropriate agency. We've nearly cleared all the stuck assessments which were well documented, and also we've done really well to reduce a number of the backlogs in registration. A good example of that is around home care, where some of those backlogs have been reduced significantly, and the registration colleagues have been working really hard on that. And as people will know, we had a new responsibility to assess local authorities' adult social care functions, and we've completed 158 of those local authority assessments and gone around every council in England within 2 years, and look out in July for a report that summarises the findings from those assessments. So over the next 6 months, we will be looking to continue to increase the number of inspections that we're delivering. The core purpose of CQC is to secure assessments or inspections for us to deliver quality regulatory oversight for the public, for government, and for policymakers across health and social care. We've made progress on that. We're on target to meet our agreed business plan target of 9,000 assessments by September. And I know, in adult care, for example, we delivered about 55% more inspections in 2025-26 as we did the year before. So we're seeing an increase in the number of assessments that we're doing. More to do, and we're going to be working really hard on different productivity initiatives to make that easier for our inspectors, but also to make sure that we can deliver more inspections more consistently to secure that regulatory oversight. Working really hard on the digital systems. We know how frustrating the problems with our digital systems have been, both for providers, but equally so for members of CQC teams, who have found that often a real barrier to doing their job. And of course, we really want digital systems to do the opposite of that. And we're working really hard on those and making really good progress on what they look like. And you'll begin to see real progress, I think, by the end of this year on some of that. It's really important that we get the assessment frameworks right first, to inform the digital systems and not the other way around. So watch this space for more of that. We've begun to implement ahead of the new assessment frameworks and ahead of the new systems a number of changes which we think strike a better balance to increase our regulatory oversight, i.e. do more inspections more regularly, but in a way that allows us to do that more quickly and efficiently. We think therefore reducing the burden on providers, but also making us able to get around more providers more quickly. You know, we hear the message loud and clear that dated and aged assessments are highly problematic for providers, both in terms of reputation, staff morale, but often commercially as well. So we're really keen to make movement on that. So, for example, in adult care and in primary care, we piloted and are implementing a return to good methodology. This is where we take a shorter, sharper version of the assessment framework, where our intelligence suggests that a provider has probably remained at good. And we can do that quicker, shorter, sharper inspection to secure that good rating on an updated basis. If we go on, on site and speak to the provider, and we see something which actually we've got concerns about, we can open up a full inspection. Or indeed, and in adult care, we're seeing more of this than we ever have actually. If we see really outstanding care, likewise, we can open that up and make sure people have got the ability to evidence outstanding. But the evidence so far from these bits of work is it's a really good way to secure quality assessments and inspections quickly that will allow us to get around more providers more routinely, which will be in everyone's interest. We're piloting the draft assessment frameworks, which we'll talk about today. And then finally, and perhaps most importantly, in a number of our areas, we're introducing portfolio management. So if I use adult social care as an example, providers tell me what they really value is a collaborative approach where they can bring up an inspector, a lead inspector they've got a relationship with, test an issue, talk about something that's concerning them or a change they're going to make, and look to get our view or update us on what's happened and what crucially the provider might be doing to improve the situation or rectify it ahead of an inspection. It's in everyone's interest that we and providers are proactive in our relationship so that regulation can be both collaborative and preventative. We don't want to do an inspection and find an issue that we didn't know about that could have been solved and sorted with a phone call. And to do that, we're really committed to re-establishing what we call portfolio management or relationship management, where a set of CQC colleagues would have a set of providers that they build an ongoing relationship with. When I was with a provider in Doncaster and again in Cumbria recently, they talked to me about how valuable that is, the ability to pick up the phone, have a relationship with someone and be able to pick up issues around regulated activity, perhaps issues around registration, perhaps issues around medicines management, and get some advice, support, or just let us know what's happening proactively. And that was reassuring for everyone. And I think that's the kind of approach I want as a chief inspector. And I know my chief inspector colleagues are in the same viewpoint. Okay, if we move on. So, as I said, we're going to reintroduce sector-specific assessment frameworks. So each chief inspector will have their own sector will have their own specific assessment framework. We think that's absolutely the right thing to do, and our consultation at the end of last year really supported that. We want to be clear what each rating means in practice. So for each element of the assessment framework, what does outstanding, good, requires improvement, or inadequate look like? And we're reintroducing those, and I'll talk about that in a minute. We don't want it to be a mystery. It's not like an exam. We want to be clear what we expect without being so prescriptive that we take the personalisation or the uniqueness of each individual or indeed provider out of the equation. But we do want to give a sense of what we're expecting. We think that's a really important tool for A, improving practice, and B, it helps us in terms of delivering consistency across inspection teams, which is feedback we see a lot of. We think the current framework is too duplicatory, and therefore it takes a lot of time to show compliance against, but also to inspect. And that's at the cost of securing the number of inspections we think we need to do to secure regulatory confidence in the sector. So we want to reduce duplication. Absolutely important that user voice is included throughout. We think a rating at each question level rather than each key line of inquiry, which is what we're determining to replace the term quality statements with, is important. and continuing to adopt the I statement, which I think is a real powerful way of linking what we do to what people say matters most to them in terms of health and social care support. We move on. So we know then we have to link this through and give assurance how all this fits together. We've got a little jigsaw puzzle here. First thing to stress is the regulations in the Health and Social Care Act and the associated of 2008 and the associated regulations of 2014 haven't changed. The assessment framework, the way of supporting CQC staff and the public in a kind of digestible way, show compliance or check compliance against those regulations, but the regulations haven't changed. So the core things that are set out in law haven't changed. The assessment framework, we hope, gives an accessible way to link that. The ratings characteristics show, a narrative against each of those key lines of inquiry to show how the assessment framework, different levels can be met within each element of those assessment frameworks. And crucially, we also have guidance, which again can be developed as we go, can be developed later as more things become apparent as needing specialist guidance, can guide us through particular elements of the regulations and the assessment framework. And that's where we've got the ability to change things as, for example, technology develops. That just shows how all those four things link. The key thing for me is the regulations haven't changed. This is about the assessment framework, giving us that framework to assess those regulations, but they haven't changed in and of themselves. We can move on now. So a little bit about what's coming. Feedback closes 12th of June. Sector-specific user voice focus groups are going to be in June too. We've got online sector-specific events, lots of informal work going on with smaller groups, testing stuff. We know we're going to be doing work co-designing the new digital and technology systems. We think that's really, really important. We've got to test this and get it right. One of the mistakes, I think, from last time, when some of the changes didn't deliver what they were intended to, was probably didn't get the testing right. And I think the testing, it needs to be tested, both with CQC teams and with providers, and doing that together, I think, is where the value in that will be. We also know we're doing work around our registration process that we're working on in terms of the process behind that, how we can use technology, and really having a look at the registration process around streamlining that for everyone. And then, of course, probably looking back end of 2026, early 2027 around implementing the new assessment frameworks. Not committing fully on a date on that because we want to get the milestones right. We want to get to a load of checkpoints to see whether you're ready to go. I'd rather get this right than do it too soon and have to then change things later. Can move on. So we know today we've got representation from providers, national representative bodies, CQC colleagues. So please, we do value your contribution. We appreciate your time coming. And I think together this will really help us deliver a product that will be make a big difference across our regulatory work and across your work as providers and the day-to-day work you do to deliver great care across the country. Brilliant. So I think I'm handing over now to Ro, who's going to talk about some of the common questions in the framework. Thanks, Ro.
Thanks, Chris, and thanks for the great overview of everything that is going on and all the work that is happening. Great to see lots of activity in the Q&A as well already today, so thanks to everybody for that. And this brings us nicely to the first of today's interactive sessions. So if we can just move on to the next slide. So I'll bring up a slide in a minute that you'll see some questions that we've posed, and these are overarching questions and they relate to all of the draft sector frameworks, and we'd really like to hear your thoughts on these. But if you have other questions to the ones that we've included or other areas that you'd like to feedback on, please also think about those and you can include those in your feedback too. We're going to capture some feedback using Slido today. So we've used this at our in-person events and we've used it at big online events as well before Christmas. So hopefully it will work well for us today, though I don't know if we've ever quite tested it with this many people on the call. I think we're looking at over 1,000 people on the call, which is brilliant. So you should see that links for the Slido for the different sectors have been added to the Q&A, and I believe they've been pinned in there. So if you can please navigate to the link for your relevant framework that you want to give feedback about. And just to say, we'd like you to record as much detail as you want. All of the feedback that you include will be reviewed. And just to reiterate what Laura said as well, you can press submit within Slido as many times as you want. All the feedback will be captured and it won't be lost. And it'll also help us to discuss some of what we're seeing coming through from the Slido feedback in real time. and we're going to keep an eye on that and start discussing that as a panel. So if we can just move on to the next slide, you can see some of the questions we'd like you to think about initially. So what we're interested here in is your general reflections on the draft framework. We're interested to know whether you think the language in the framework resonates and aligns with your sector, and whether or not you have any reflections on things like the structure and layout of the draft frameworks. So I'm going to hand back to Laura now.
Thanks, Ro. That's really helpful. While we're waiting for people to start adding their reflections on these questions to Slido, I might come to our policy DDs first, if you don't mind, to talk about what you think the key differences are between the sector-specific drafts and the single assessment framework. Ro, if you don't mind, I'll come to you first for any thoughts on that.
Yeah, absolutely. Happy to start that off, and I'm sure colleagues will want to add to whatever I say. So I suppose one of the key things that we've been seeking to do has been to sort of reduce some of the duplication across the frameworks. There's been a reduction in the number of what were quality statements and are now CLOEs. So we've gone from sort of 34 to 24 broadly. Certainly in ASC, it might be slightly different numbers for colleagues, but yeah, seeking to reduce that duplication, reducing the overall number of CLOEs within the framework. Also, I think that one of the key things I draw is that sector specificity that we've sought to bring. So bringing those, making those frameworks work for the different sectors. So sort of adding that detail that makes it relevant to each sector. But I'll hand to colleagues just in case they'd like to add anything to that.
I suppose building on that, there are certain areas that will have strengthened or taken a different focus on in different sectors. So across all the health care frameworks, for example, will have been looking to the NHS 10-year plan and the move towards neighbourhood work and multidisciplinary teams and so on. But then within mental health specifically, we've taken a lot of care in looking at how we reflect the Mental Health Act and the requirements of the Act, and that's threaded through the framework. Also, we've looked at making sure we're really strong on choice and independence as well in that framework. So yeah, those are some of the areas that we're focused on in the draft for mental health.
Thanks. And I think on the hospitals one, a couple of things to pull out. So as well as the reducing duplication and trying to streamline, we've also improved our focus on clinical outcomes. So whilst we've always looked at that in our inspections, it wasn't as prominent in the single assessment framework, and based on lots of feedback that we've had, it's now a separate kind of key line of inquiry in the effective key question. And another change that we've made in the well-led section is we had lots of feedback that under the single assessment framework, we had this one quality statement on kind of governance, performance management and risk, and it was just too big as a topic to have it as one area. So we've separated that out into a couple of different areas based on the feedback that we've had.
I think this is more of a general comment, but one other thing I'd say in terms of how the frameworks have evolved from the current one, in addition to the points that others have made, is that we're increasing the focus on inequalities and equity and looking at building that in across particularly the range of key questions that we include in our framework. So when we're looking at things through the lens of patient safety or the effectiveness of care, making sure that there's a space in the framework and in the ratings characteristics in our reporting for each of those key questions to clearly show the equity and inequalities implications of that, rather than grouping it all into a single place as it has been in the single assessment framework. That should enable us to strengthen how we look at those areas and incorporate that within our judgments as well. Thanks.
Thanks, Matt.
Just to come in briefly, I suppose I said about reducing duplication, Laura, and I suppose really clear to say that we still think there's more that we can do. I think there's still further areas that we can reduce that duplication further, and we're really interested to hear views from people about where they feel there is still any duplication or repetition across the frameworks. I think I can see there's a question in the chat about that, so just wanted to come in and address that. We definitely don't think we're all the way there yet, so I guess that's why we're really keen to emphasize, as you did at the start, that these are very much drafts, so really open to suggestions and feedback on that.
Thanks, Ro, that's really helpful. And Sorry, Dave, were you coming in?
So I was just going to say there's some comments as well around where certain topics have gone and have we lost certain things. We've been focusing on duplication and addressing that, and actually all of the content that was there before is still there, and that probably poses another question of, is there still too much as well as duplication? Are we still too broadly setting out what good looks like here? But if you are wondering where your topic or something that you have a particular interest in, it may well have moved to another key question, so it's worth looking across the framework. We're not conscious of having lost any actual content, rather we've been focusing on making it more clear and less duplicative.
Thanks, Dave. I might then come to Chris and then Tolly to think about some of the key changes we're making or we're going to be implementing as part of these draft sector frameworks that they might want to focus on or bring to the fore. I'll come to you, Chris, first, and then Tolly for anything you want to highlight.
Yeah, thanks, Laura. And I think it's important to sort of cast the assessment frameworks and what I think is my overall position around what we're looking for in quality adult social care. At its heart, quality adult social care is really two things. It's personalised and it values the safety of people who are supported and actually staff, right? So safeguarding and personalisation in the sense of the two fundamental principles. With those two anchors, I think it makes everything that we're doing sort of easier to understand and navigate through. Those are clearly brought out really strongly within the frameworks, and I think personalisation is an important one. We want to be as prescriptive around, or descriptive. We want to be as descriptive as possible without being prescriptive, because if we're prescriptive, we go against precisely that principle that I've talked around, which is personalisation, right? So there's different ways of achieving the same outcome in different places across the country, different care settings, different individuals. But at our heart, we want people to be able to show they're delivering personalised and safe services. And within the assessment framework, by being, to a greater or lesser degree, consolidated and more, I think, focused, gives us a real opportunity to do that together. So that's just a couple of things I wanted to mention about the framework. And to echo Rose's point, I still think there's some duplication in there, but we thought it'd be better to seek views on that, because there's going to be different ways to reduce that duplication, rather than be really reductive early on and then in a sense have more work to build it back up again. So we do genuinely think it will reduce down further. I think the question is how best that we do that, and what are those things that are most clearly duplicative. But do feedback on that. It's something we're really interested in.
Thanks, Chris. Really helpful. And Tolly, I'll come to you now.
Yeah, thank you, Laura. And following on from the point Chris was making, we want the benefit of the sector-specific framework, but really avoiding the risk of sector silos. So, the four of our inspectorates, our sectors as chief inspectors, our teams, we all need to work together, which we are doing, to make sure that we keep the benefits of our sector specificity, but avoid the silos. And the issue about the avoidance of duplication, I think that also fits with avoid duplication, but ensure consistency. So we need to have a broadly consistent approach to some of the key areas that cut across all our sectors, like safeguarding, like staff well-being, freedom to speak up, whistleblowing. Those things, we need to be sort of consistent in our approach to that. With the frameworks, colleagues will have noticed there are lots of consistencies, and at high level, this should be broadly similar, but also we're really conscious of taking the opportunity for our sector specificity as we work out our guidance that sits beneath our frameworks. So every sector regulates a real breadth of services, every sector. I can only, speak in the most informed way to my own sector, the hospitals, secondary and specialist care. And of course, that covers independent health, it covers, acute trusts, specialist trusts, ambulance sector. We need to make sure that our guidance that fits under our framework can be applied to those areas in a way that, is consistent, doesn't duplicate. We've seen, for example, questions in the chat around regulation of the hospice sector currently sits with hospitals, but much of that is community. As long as we're consistent and our approach across our sectors aligns, we should be able to inspect in an intelligent way and get rid of some of those frustrations that providers have had in the past about taking a different approach to things. So, we really appreciate feedback on that and making us think about those things. Thank you.
Thanks, Tolly. Really helpful. Also seeing another comment coming through about the mapping to regulations and making the point that only tend to see what regulations are breached in key questions, current quality statements when there's a breach, rather than good examples of how regulations are met. Does anyone want to come in on that?
Do you want me to make a start? So I think there's a couple of bits there, Laura. There's something about how we're clear how the framework links and maps to the regulations and how we can bring some more clarity to that. And certainly that's one of the things that we've been hearing as we've done some engagement on this so far. But then I think there's also that, how do we do more to share what we're hearing in terms of good or outstanding practice within the various sectors. And I know, Chris, that's something that you've been particularly interested in. How do we do more beyond our kind of annual state of care statutory report? How do we get more agile at sharing the good things about what we're seeing and sharing that best practice to help the whole sector or sectors improve? But Chris, I don't know if you want to add anything to that.
Yeah, I think it's a really good point. Look, we whether it be things to avoid or things that are great, particularly as the world is moving so quickly around, for example, technology, but also the kind of complexity of care that people are supporting at different levels has changed. It's really important that we share that best practice. We have a unique position around going into so many, it's a privileged position going into so many care providers. We need to get back to a position where we're much more proactive around sharing what we see on a regular basis, and that's not on an annual basis. So I've had conversations indeed this week with some of our specialist inspector colleagues and also a communications engagement team about how we can do that, so we can get regular updates around, where we see outstanding care, let's share it. We're consistently not great at sharing best practice, for example, in adult social care. So how can we do that more consistently? Last month, we saw the most number of outstanding assessments than we'd seen for a couple of years, which is great news. But we need to, each one of those outstanding inspections is an invaluable opportunity to share best practice. Indeed, it might just be a single Chloe in the future that's outstanding, and we could be sharing that. And again, using tools to get those messages out. So watch this space, but certainly from the autumn, I think you'll notice a real difference for something we're giving it a go in adult social care, about being much more sort of front-footed about sharing that best practice. And that's something I'm going to want to seek feedback from providers and professionals on how well that's being received, and we'll work with them over the summer to get that developed, hopefully in a really effective way.
Great, thanks, Chris. Tolly.
Oh, thank you, Laura. I'm following on from the point that Chris was making. In our sector, we know we have been pretty risk-based in terms of doing our inspections, and sort of forgive us for that. I think it's a consequence of having fallen behind and become late in the sequence. We've had to target in a risk-based way, but we know ourselves that's not what we want to continue doing. And in fact, just yesterday within our exec team, our colleague Bola Owolabi, who's Chief Inspector for Primary Care and Community, she talked to us about us taking an appreciative inquiry approach, both internally in how we work in CQC, but also now thinking about how we reflect that in our inspections and our reports. So what we mean by sort of the appreciative inquiry bit is, taking a more strength-based approach to it, looking at, what's good, not just going for the deficit angle, being constructive about it. And that ties in very much with what Chris was saying about, the purpose of regulation isn't just wielding a big stick in a legalistic way, but seeking to support providers with making those improvements that patients and service users are telling us are necessary. So we are internally ourselves want to take a more positive and developmental view to how we manage within our organisation, and we absolutely want to reflect that in how we inspect and report. And that doesn't mean we're going soft on enforcement. Of course it doesn't. We will still do what we need to do in an enforcement sense, but we don't want to have a sort of sense of being punitive for the sake of being punitive. we want to be developmental wherever possible. Thank you.
Thanks, Tolly. Excuse me, there's also been quite a few questions around hospices and where these sit in terms of frameworks. I'm not sure if it might be helpful for people to have a bit of clarity and discussion around that. And Vicky, will I come to you first on that?
Yeah, of course, happy to. So I think this is a tricky one, and I think there are a number of services that don't neatly fit within one of the 4 sectors, and hospices is one of them. And I can see in some of the chat and the Q&A there are different views about where hospices sit and whether they should be community or not. I think so. We haven't got a kind of a black and white answer for you at the moment, but please be assured that we are looking into it. And I think I'd echo what Tolly said, which is there are large parts of the primary care and community framework and the hospitals framework that are similar. And I suppose at this stage, what will help us in determining kind of how, which framework and how to inspect hospices, please give us feedback on the content and how they can be applied in hospices, because that will help us with determining which framework and also thinking through what service level or service specific guidance we need as well. So I hope that helps for now, even if it's not a black and white answer at this stage.
Thanks, Vicky. That is helpful. If nothing else on that, I was going to, there's been quite a few comments coming through around the guidance, so a strong demand for clearer, more accessible guidance, and a single comprehensive guidance document like the old fundamental standards guide. Does anyone want to talk to how we're developing guidance alongside that and what the kind of intention is?
Do you want me to start off, or you've come off mute as well, Dave? I don't know if you want to start off.
Well, I probably would have been talking about some of the work that you'll be kicking off that sort of explores how we do guidance better than we've done to this point. But before that, I suppose it's true to say that with the introduction of the SAF, we wanted to produce more detailed guidance so it's clear which aspects of the SAF related to which services and how they differentiated. And that's one of the things that we got wrong and failed to do. So we absolutely do need to do that now, even though we've got at current count 4 draft frameworks. We know there's more difference and nuance below that level. So there's a huge amount of work that we need to do with you, as well as with people that use services and our wider partners on the content of that guidance, how we can keep that up to date and make sure that it's not onerous for you to understand what it is we're looking for and how it can be really clear what good looks like and the evidence that we'd look at for your service. But yeah, I don't know if you want to add anything, Ro, about
so I suppose
approach.
It's just worth saying that historically we've had different approaches across the organisation and different approaches across different sectors to how we did guidance and how we sort of articulated what that framework meant for different sectors and service types. And some of that was published externally and some of it wasn't. So we're doing a bit of a review to look at how we do that in the future and how we do that going forward. So really interested in people's views, but we're committed to ensuring that both providers and people who use services and also our own teams within CQC have an understanding of what the framework means for different types of services that we inspect. So the framework will always be that sort of high level articulation and it won't give all of the detail, but we know that there's more that we need to do to make sure that people have the detail that they need, both to support them to understand our expectations and both for our staff to assess against those expectations.
Thanks all. We're shortly going to be moving into the Q&A, but just to say these feel free throughout the rest of the session and they'll also be live after today's event as well. You can keep on providing feedback on this, but I'll just come to one last comment before we go into the Q&A. So it's about timely and equitable access. Is still unclear what this is and could easily be wrapped up with equity and outcomes. Does anyone want to speak to that point? I think it's in relation to adult social care, so I might bring in you first, Chris.
Yeah, I can come in there, Laura, if it helps colleagues. Yeah, so this is an example within the adult social care framework where equity of access and outcomes, I think, is an area where we've already identified where we could potentially remove some duplication. We have to also be really clear around, access and equity of access means quite a different thing in an adult social care provider than it might do in, for example, where we're assessing, a GP practice where people are going in for sort of visits often regularly, whereas adult social care provision is often can be 24/7, 365 days a year, and you're not making an access choice every day, so to speak. So that is an area I think we've got duplication, and that we can refine that down without losing the focus on equity and inequity, which is something that through all the assessment frameworks we've got a really, really clear focus on. That being said, that is an area that is a good example and illustration of something that I think is duplicative and that we can probably get consolidated down. So a really good example. Thank you for sharing.
Great. Thanks, Chris. We're now going to move into the Q&A, and I know quite a few of you have been adding questions throughout session 1, and we can have we'll do this until about 2:05 before we move into the next session. So some of the questions that are coming through are around we obviously had some on guidance, we had some on hospices. Sorry, just one.
There's one here, just Laura. I wonder if it's
Thank
worth
you.
pulling out, and I suppose it'd be good to get your thoughts on this, Chris specifically firstly, but I'm sure Tolly you might want to add. The question is around you having mentioned that 76% of people make decisions based on care by reviewing reports and ratings, but it's talking about the fact that some providers have been sitting with RI ratings for a number of years, and the question is sort of asking about what's the plan to kind of address that moving forward and sort of fix this moving forward is the wording. I just didn't know if you wanted to say anything more broadly about that and plans to increase inspection numbers.
Yeah, absolutely, and what I say, we talk about this almost daily with other chief inspectors, are common across the sectors. But yeah, look, in a sense, I absolutely agree with diagnosis of that problem, that people use a CQC report, yet they're in some cases and far too often out of date and too old, and that's got 2 problems. Firstly, it could be out of date and actually that service is rated as outstanding 7 years ago, but actually an awful lot can change in 7 years and it may not be that, so we're giving a false message. Or providers perhaps rated requires improvement a number of years ago and have made a load of changes, and it's really important that those changes are recognised so people can use that latest view of the quality of that service to make a decision, but also for the morale and well-being of the colleagues that have really worked hard to change and improve. So it's absolutely why I know I and Tolly and the other chief inspectors have got what I'd only best describe as a relentless focus on increasing the number of assessments we do. Now, we don't want to do that at the expense of quality and consistency, but we think there are some things that we can do even ahead of the new system that will make that easier. So I've talked a little bit about the return to good methodology, which will allow us to do more inspections more frequently. I think in adult care the reports are too long. They're much longer than an Ofsted report, so how can we make those reports shorter and tighter, more accessible to the public, but focus more on the feedback we give to providers immediately after the inspection or during the inspection for things they can do to improve or things that we think are outstanding. Shouldn't be doing the feedback in the report. The report should be for the public, and the feedback should be the thing that the provider uses there and then to deliver change. And the other thing is clearly we're considering how we use artificial intelligence. Everyone else we talk to in different regulatory environments are using that, and we're beginning to explore that, not to make human judgment, but rather to support and enhance and magnify human judgment by making some of the other time-consuming tasks easier and quicker, which allows people more space to use their professional judgment and physically and metaphorically cross more thresholds to see more services. So just a few examples of that work. That's something we're monitoring really closely, and we're working really hard on to drive the number of inspections and therefore reduce the number of dated ratings.
Thanks so much, Chris. There's also a question in there about can we clarify whether all CLOEs within a key question need to be assessed in order for the key question rating to be changed, or can the rating for safe change if only 2 of the CLOEs are assessed, for example? So a question around our use of CLOEs. Would anyone like to start off on that? I think.
Yeah, I can start off, Laura.
Okay.
I'm sorry. Did you want to come in, Matt?
No, you can go.
All right. This is one thing we're testing as part of the piloting we're about to start doing. that we want to carry on having conversations with you about as well. So there's two types of inspection that we talk about in our consultation document that we published last year. There's the planned assessments, and then there's the rapid responsives. In a planned assessment, we're testing the idea that generally we would look at all Chloes that apply to that service. So there will be some cases that they're just not applicable for the type of service. Where they do apply, generally we'll be exploring that we'd look at all Chloes within a key question to give providers a sense of consistency, really. But there may well be circumstances where that isn't necessary. So, for example, if we found really serious issues in a service, we may stop at that point, for example. But then on the other side of the coin, we want to make sure we're making the best use of those rapid responsive inspections and to explore under what circumstances are we able to update that rating based on some improvements having been made since the last inspection, for example, and what are some of the guardrails that need to be in place around that in terms of how old that evidence can be. Because one of the things we need to be mindful of is what Dr. Penny Dash talked about in terms of mixing old and new evidence and how that can become quite a complicated and hard to follow and justify situation. So we are exploring how we can be flexible, how we can be proportionate, of course, as you'd expect, but also how we best give providers confidence in our judgments and a sense of a consistent approach and application of the frameworks.
Thanks, Steve. Anything else on that one? I've also had a question through about starting from a position where you assume that the service is good and looking at the strengths and weaknesses during the inspection is more conducive to an open and more relaxed relationship between inspectors and provider and would be more beneficial all round for better cooperation during the process. Could we talk to how we conduct inspections going forward? I think this might also touch on some of the relationship management points that we've had asked at other engagement events. Anyone like to start?
Want me to come in there first of all?
Thanks.
Yeah, look, I absolutely want us to go in with a principle that every day across health and social care we're seeing people with huge commitment going well above their contracted hours, lots of discretionary effort, doing wonderful things every day, that's sustaining the sector in the face of, or all sectors in the face of a lot of challenges. So, and I know, for example, what a hard job being a registered manager is, one of the hardest jobs in health and social care, right? So I want us to go in with a posture which is looking for good, sets that as a relationship that will lead to a more conducive and open dialogue, which then is more consequently conducive to feedback being received in a way that will lead to improvement. I think when we go in with that attitude, it will be helpful all around. Being clear that if we find things that are below a level that is acceptable for us and the public, that we're really robust in terms of taking action if we need to. But our mindset is around one that is looking for good, one that's proportionate, and one that I think crucially focuses on what I've been talking about, the 80-20 rule. And don't take that as a sort of hard and fast rule, but as a indicator of what I'm trying to seek, and which my teams are really keen to do, which is when we're doing an assessment, for example, at a care home, 80% of our kind of intellectual effort as inspectors is around the observation of what we see. So observing practice, observing personalisation, observing how well colleagues interact with one another and with colleagues, observing how safeguarding is embedded in the service, and 20% on the governance that is associated with securing and making sure that care is of a quality, consistently high quality nature, right? So, but it's the observation of practice that should then lead us to look at, for example, a care plan. So you observe the practice, follow up with the work looking at the care plan, rather than looking at all the care plans and then doing the observation. More of the effort, and our unique, in a sense, position as a regulator is the privilege of going across a load of different thresholds and seeing, hearing and experiencing quality care. So looking for good, and looking for good with an observation centred approach to what we're doing.
If I may follow up on that one, thank you. goes back also to the fact that CQC made a deliberate decision to go back into 4 sectors, and within the last 12 months only, bring in 4 chief inspectors from those sectors. So the 4 of us very much are steeped in provision before we've, turned gamekeeper, as it were, as regulator. And it's really important that we remember that, and that all our teams understand the complexity, the unique challenges of each area of provision, and the context in which the inspection teams are functioning. And as provision is increasingly more broad and complex, we recognise none of our inspectors in any of the areas can have all the knowledge and expertise they need. And that's why we need to have our specialist advisors. The consultation that we ran in the autumn, it came through very strongly from feedback to the consultation, the expectation that inspectors really needed to understand the area they were inspecting and regulating, and therefore be supported by specialist advisors to help with their professional judgment. And, you'll see in our consultation now, we have said we will lose the individual scoring that we'd previously applied and rely more on professional judgment. But for that professional judgment to be meaningful, to be consistent, to be credible with providers and with the public, that professional judgment of the inspector has to be backed up by the specialist advisor. So we're having a real push to recruit those specialist advisors from all branches of clinicians who have that relevant expertise, whether you're a community nurse, a GP, an orthopaedic surgeon, a physiotherapist, and that will increase the quality of our inspections. I think there's also been comments, haven't there, about the importance of relationship management, and we are very keen to further develop that. There are challenges where we've got lots of small, for example, small independent providers in primary care, in social care, having individual relationship managers, or within independent health. But even, say, with an overall group, we can still have, relationship from our end. And I know it's been less than a year since I left being a provider. I know how important it was to us at the time as providers to have maintained our relationship management. And I come from the north of England, where the former director up there did a great job in preserving that when it was not always preserved throughout the rest of England in the hospital sector. Credit to Anne Ford, and the relationship management, is so important. So absolutely, thank you.
Thanks, Tolly, really helpful. We've had a few questions around timescales. So one is around the planned timescales between initial registration and first inspection for new providers. Dave, can I come to you first on this one?
Yeah, sure. It's we've had similar questions from other similar events. So I think the really important thing to say is we absolutely must get back to giving providers clarity on the expected timeframes for inspection. So that includes following first registration, when would you expect to be inspected and rated? But equally beyond that, what's the longest period of time? Might that be different for different types of service or different sectors? Might it be dependent on risk or the current rating and so on? That is essential work that we need to do, which we can't do now, because we need to understand how the revised methodology, how the sector frameworks work in practice. But our absolute aim is essentially, I'll put it bluntly, to deliver a better service to providers. So to do more inspections, to keep those ratings up to date. So everything needs to hang together, and it's about more than just the frameworks. It's about how our teams are supported and have the right skills, and we're able to get sufficient inspections done. When we understand more about how the revised model works, then we're better able to give really strong assurances, and we'll publish that statement, and we can be held accountable against that. At the moment, as we move through this testing and development stage and get to that greater clarity that we all strive for, we publish our priorities by sector, and we set out our objectives essentially, and how the priorities for different sectors stack up. So providers that have yet to be rated because they're newly registered are within those priorities, and we apportion our work in line with those priorities. So we'll continue to publish those, but that's really a holding pattern for us getting back to, as I say, what many of you will remember, which is that really clear statement of how often you can expect to be inspected and for ratings to be updated.
I was just going to add to that, Laura. I know certainly in some sectors, and speaking for adult social care, there's definitely been a conscious move over the last few months to move away from just inspecting for risk, and for so long we've been focused just on responding to that risk, but instead looking at ratings that were particularly old or aged ratings and trying to bring some balance to both the sort of age profile of the services that we look at in terms of time since last inspection, and also to the different types of services that we are inspecting to make sure that those are representative of the mix within the sector as well.
Thanks, Ro, really helpful. Another question that's come up is around the primary and community care return to good. So how will these spot outstanding and allow us to rate for outstanding? And will we publish the 10 non-clinical quality statements? Matt, are you happy to make a start on that one? Or anyone who wants to come in on that?
Yeah, so the general approach is to, with those return to good programs, is to focus on the bits that we can sort of touch quickly and assess the sort of non-clinical quality statements. But if we find evidence that we need to, that the rating might have changed essentially, we would then open that out into a full inspection and bring in specialist advisors to cover the remaining aspects of the relevant key questions. So you would essentially turn it into a fuller inspection in order to rate up or rate downwards. So that's the general approach. I must admit, I'm not sure off the top of my head what exactly we've said externally about that in terms of the specific quality statements we're using. I have to come back to you on that.
Thanks, Matt. That's helpful. I think unless there's anything else people want to, actually, sorry, a question has come through on plans for piloting. Does anyone want to touch on plans for that going forward?
I'm happy to comment on that, Laura.
Thanks,
Yeah,
Tolly.
thank you. So we have made our plans for piloting over the summer and autumn, and we're going to start with a range of services across all 4 sectors. And initially, we're going to pilot not in an electronic system, but in Word templates to just look at how the framework would work alongside in parallel with our existing inspections. So no provider will suddenly have a pilot arrive on the doorstep. We will confirm with the providers that they're comfortable to be included in the piloting program, and if they're not, they won't be. But the aim is to do it in parallel with our inspections, and then to use how the application of the framework to get that feedback to help us design the underpinning digital system for it. So work's already going on with the digital systems, but the refinement of that will need what we get from the pilot, and then that will be the first phase of our piloting, and then we will have subsequent piloting later on as we've incorporated that feedback. Policy colleagues, I think that's fair, but please correct me if, yeah, you're good with that. Thank you.
Yeah, as you say, there'll be a sampling sort of piloting of the new sector frameworks across a range of different sector types. We're planning on an initial sample of 40 inspections beginning in June. We're working on getting those set up, as you say, using primarily, if not entirely, existing planned inspections that will be coming up over that period, and we'll be piloting throughout the summer really, and building that into the evaluation approach. As you say, there'll be digital development happening in parallel and built flexibly to accommodate what we're going to be piloting, but then once those digital systems are built, they'll be refined and further tested ahead of final rollout. That's the overall approach.
Thanks, Matt. That's really helpful. And just to confirm, anything that's going forward with that, we'll communicate with you and look out for further information on that. But thank you. I'm now going to pass to Dave to introduce our next Slido session and some general questions on the draft assessment frameworks. Thanks, Dave.
Thanks, Laura, and thanks everyone for all your contributions so far. This has been great. So we've got a few more questions on the next slide, and it's the same approach. So choose your Slido link that works best for your particular type of service, and please share your thoughts with us. We've got a few questions on the next slide, which I'll talk through. There's on Holly. Thanks very much. So yeah, 3 questions, and actually I think there's been some comments that have touched on these things already, so that's really helpful. First, we're really keen to understand how well you think the draft frameworks focus on outcomes and on the experiences of people that are actually using those services, and there's definitely been some thoughts on that already, so please share further what you think about that. Do you feel the draft frameworks embed equity and our human rights approach consistently and clearly enough across all key questions? It'd be great to get your views on that. And again, we've touched a bit on this, but what else is needed to support the understanding of the draft framework? For example, at service level, but it might be population group, a diagnosis, or whatever that might be. And feel free to kind of go for broke on that. We've talked about our approach to guidance and how we want to improve that, but maybe there's other things as well and other ways to bring that nuance and that variety and detail to life. So it'd be great to have any thoughts you have on that too.
Thanks, Dave. That's really helpful. I wouldn't mind asking some of the policy DDs, Chris and Tolly, if there's anything you want to kind of flag that you think is particularly interesting around these points, or anything that you want people to particularly focus on in relation to these.
I think certainly it's really important for us, and Chris referenced the I statements earlier, and the fact that those will be being retained in the future framework. So really important that we hear your feedback about how well the draft framework focuses on those outcomes and experiences for people who use services and draw on care and support. And in addition to these sessions that are sort of involving lots of different stakeholders, we will be having some focus groups in June with groups of people who use services or those who represent them as well, but keen on views on that from our point of view. I suppose the other thing that's not on this list, but I suppose the thing that we've not really mentioned is if there are areas that you feel that don't have sufficient prominence within the frameworks or don't come out clearly enough, we'd really like to hear about those as well.
Thanks, Ro. That's really helpful.
I suppose just to jump in, I suppose from my perspective, if it's okay to jump in, I think there's been some interesting comments in the chat, and I think we've talked about some of the different service types that this needs to apply to and how it applies to different services. But there were also kind of other kind of ways of looking at this. I think some comments focus on the independent sector versus the NHS sector and how we reflect that in the frameworks. And also some kind of comments about small versus large providers and services. And I think for me, a common question or common thing across all the frameworks is just making sure it's able to be applied in those different settings across the sectors. So for me, that it's not just about sector by sector, but it's size as well and some of those aspects. So yeah, welcome comments on that as well.
Thank you, Vicky. And just while we're looking at some of the comments coming through, can I ask people to use session 2 on Slido? So you can toggle it at the top of your screen. You'll be able to see a way to do that, but it's session 2 will bring up these questions. Thank you very much.
Just wonder, there's a question here, Chris, that you might like to comment on in the chat, and it's around the kind of the inspections being more focused on observation and less on sort of paperwork and process. And I know you've talked about that a fair bit recently, and sort of talking about wanting to move towards sort of 80% of time on site being more focused on observing and interacting with people who are using the services and people who work there versus sort of less time looking at kind of documents and paperwork. So I don't know if you want to sort of say, there are the questions asking about how you will ensure that inspectors adhere to that.
Yeah, thanks. And as I said, it's not a hard and fast rule, because you've got to be dynamic around what you see when you come across a particular setting. But look, it will be, and it's already part and parcel of our kind of guidance to inspectors. It's something actually the inspectors have said that they want to do. It's better, there's an ability to, sometimes you absolutely have to look at supporting governance and the quality of documents. Like, I'll give an example, particularly to ensure continuity of care and safe continuity of care. Quality, clear, unambiguous care plans, including around medication, etc., are clearly important, right? They're absolutely vital. So it's not to downplay the importance of that work, but when you're on site, observation must come first and must be the focus of what you're doing. There's no point doing something on site that you could be doing offline, in a sense. So the time on site is highly precious, both because of we know how much sort of mental and physical resource it takes out of providers when we're on site. We know how, it can create anxiety. We totally understand and recognise that. So we've got to make that purposeful, and that's got to focus on the experience of people receiving care and the experiences of colleagues working in that care setting, because that we can only do that when we're on site. And I think that's really, really important. It may be that we do more effort on the governance side of things, or some of the important policies and documentations off-site. We might do that. We're clearly, as work of our management and oversight of the teams, like a provider would have policies and processes in place to understand how different inspectors operate. It's not going to be one size fits all, but we'll have some underlying principles that we will help inform what we do, and we have a management hierarchy that allows us to monitor that and support colleagues develop their practice as inspectors, in the same way that we'd want to see providers developing colleagues within their settings to develop their practice. So similar principles apply. It will always be a work in progress, but that's the kind of direction that certainly I've been clear I want us to go in.
Thanks, Chris. Just to say, there's also been quite a few comments coming through about positively about the frameworks. Someone said that the framework reads really well, nothing to strongly disagree with, but they did want to know how services can show they keep people safe. How do we know what evidence we need from a provider point of view? I think the comment came through in mental health, but happy for anyone to touch on that.
Very happy to comment and take the compliment on behalf of this team that have done the work. No, that is really good to read. I think that's what we need to do, is to be clearer on what is the evidence, and how do we best set that out. I think that's one of the things we're kind of driving at, and with our third question, I suppose, here is what is it you need from us, and how do we make sure that's flexible enough to be able to adapt to the range of services, not just within mental health, but we want to be clear on the evidence that we look for, but at the same time make sure we're not creating tick lists for you and for us as well. So it's about harnessing what we talk about in question 1 there, about the outcomes and experiences of people, and being clear on the evidence that we'll look for. But as I say, without turning that into a checklist. Sounds like I'm answering a question with a question. But thoughts on how we do it. But we definitely want to work. Again, we want to work with providers and with others to really build out the aspirations that the high-level frameworks articulate in terms of what good and outstanding look like, and so on. Then, yeah, what evidence should you be compiling, so that we we've got a shared understanding and we're transparent about how we come to those judgments.
Thanks, Steve. I see that there's a comment around dental services. I think it's around unrated services. Could we touch on that, Matt?
Yeah, thanks, Laura. There are a range of different service types that we don't rate. We inspect them, but we don't award ratings. Some of those are joint inspections. So, for example, with the Prisons Inspectorate or Ofsted, we don't rate those services. We also don't inspect dental providers and some other specialist service types as well. So we said in the consultation and in our statement that we published 6 weeks or so ago, alongside the assessment frameworks, that we'd be looking at the approach to unrated services and how we align the inspections of those unrated services, which high level rated framework, what sector specific framework they align with, and how specifically we do that through supporting guidance. So certainly well ahead of when we implement the new assessment approach, and when we publish the frameworks, we'll be clear on exactly how that's going to work for the other service types that we don't rate. Some of that requires discussions obviously with Ofsted and HMIP. Some of it we can decide and articulate ourselves through supporting guidance, but we'll certainly be working that through as to which the relevant framework is, what the supporting guidance is, all of that. So that's still coming. Yep.
Thanks, Matt. Another comment about, will we be reviewing whether you can take any assurance from organisations that provide accreditation, certification services, such as the Royal Colleges, private companies, UCAS, etc. Would anyone like to come in on that? As Tolly, was that something you'd like to start on?
Yeah, thank you. I'm happy to respond to that. We definitely want to think about how we can use that information better. So we do already have comment on our website around how we use certain Royal College accreditation, but where can we use that more broadly? You know, once we've, not necessarily Royal College, any form of accreditation, we need to sort of QA ourselves, don't we? But for example, we know how much work goes into many of the Royal College visits and accreditation for providers, and we don't want to create duplication for providers. So where we can, you know, rely upon that, we would like to. And in our world of regulation, in the Venn diagram, there is a big overlap between what we look at through regulation, what a college looks at for accreditation. But of course, it's not the whole of regulation. We'll still have areas we need to look at. But, you know, it is a really important source of information. And if it's reducing the burden on providers and giving them more opportunity to do the work of care provision, then that's a good thing. The other thing that's hugely helpful to us, again, that has been for a long time for CQC, is information from audit. So we have a good relationship with HQIP, which looks, you know, collates all the national clinical audits on a whole range of areas. And that allows us to see outliers. And, you know, as we were talking earlier, it's not just outliers, you know, and the sort of third standard deviation from the bottom. It's also the outliers who are really good. You know, we need to learn what has made these outliers so good that they are outstanding. So again, these are areas where if we have the right data and insight before we go into a provider, we know what we already know. And then when we're in there, we can focus on what we don't know and what we want to collect from on site. So yes, I think that's fair. We need to do more of that. Thanks.
Fantastic. Thanks, Tolly. I see another comment coming through in adult social care about having hydration and nutrition more prominent. Would anyone like to come back on that point?
Yeah, I'll come in, and if Chris wants to add to it, he's very welcome. I suppose that's something that we've heard from some of our internal colleagues towards at the beginning of this year when we did some internal roadshows. And we're looking at the question as we go through this sort of round of engagement on the draft frameworks about whether that and some other areas have sufficient prominence, and if they don't, what are the options that are available to us for making topics like nutrition and hydration more prominent in the frameworks, and considering whether that does indeed need a standalone Chloe. So that's one of the things that we're working through and considering at the moment. I'm really interested in any feedback that people have on that specifically.
Great, thanks, Ro. Chris, did you want to add anything to that?
We've had quite a lot on this actually, and I think, you know, we are clear that, you know, nutrition and hydration is such a fundamental issue. But I mean, I actually spoke to a number of specialists in this area last week, knowing that this would come up as a bit of a theme. And of course, in all care settings, we shouldn't underestimate the importance of you know, nutrition and hydration clinically. We know is important. That's a kind of given. But also in terms of things like, you know, indicative of culturally competent care, how important food and taste can be to individuals that may have a number of other restrictions on their liberty at that time and being, how evocative it can be, for example, people with dementia. I'm speaking to colleagues today talking about family members with dementia from different communities in the country and in England, what that meant, and actually how nutrition in particular can have a significant resonance for people in terms of personalisation. So that overlap between personalisation and nutrition is an important one, and an example, I think, around how important personalisation is in all the different quality statements.
Thanks, Chris. I'm going to come to one last comment. There have been a few coming in around removing scoring and the rationale for that. Tolly, can I bring you in this one first?
Yeah, thank you, Laura. The excuse me, feedback from previous consultations did not support persisting with scoring, and it was clear from Penny Dash's review and Sir Mike Richards' review that it has not served the purpose it was intended for. So always introduced with good intent, but has proved to be more complex. And I do remember Sir Mike saying the problem with scoring is that everybody regresses towards the mean, kind of thing. So the feedback has very much been it's not served the intent that we had, and it had an unintended consequence of creating complexity that then played out through aggregation of scoring and rating, particularly in those bigger providers where you would have site, service, location, you know. I've not put that in the right order, but you know, you have a whole range of pieces that come together to make up an overall rating. So based on the feedback that we had, as well as the reviews, we made the decision that we should not persist with scoring. I think our policy colleagues will have a better detail around that, and of course they have the lived experience of it, which I don't have. Thank you.
I think start that off. Others may want to come in. Just to say, the proposals in the consultation document around that, people may want to look at the analysis of the consultation responses that we had from the independent supplier who did the analysis of the consultation. But the responses to those proposals, including around removing scoring, were pretty overwhelmingly in favour from providers, inspectors, members of the public around removing scoring. So conscious that there is always a debate there, but it is those proposals were very well supported in terms of simplifying the approach and going back to a more holistic assessment of the evidence, a key question level without the underlying scores. One thing we did say though in the consultation, and we'll be looking at how we test this in the pilots, is that we would still report in a structured way, so that providers will have an understanding of their performance against the framework and members of the public when looking at our reports. So we need to look at the best way of doing that. We're still working through exactly how that reporting approach might work and how we might want to vary it, for different services or different sector types. So how we best meet the needs of the different audiences for our reports, which is not straightforward because members of the public and providers tend to expect different things from our reports, but we are looking at reporting in a structured way. So trying to find that right balance essentially between a more structured approach to reporting where providers can understand the evidence and the judgments that we're making against that framework, while keeping it as simple and clear as possible with a focus on how we make that overall key question judgment. Hopefully that helps.
Just to add to that quickly, Laura, we're sort of seeing comments come through about that kind of consistency in judgments with lifting the level of judgment up to the key question rather than an individual quality statement or Chloe, and something that we have heard from the roadshows as well, and certainly now there will be a need to not just, obviously we've got the introduction of the ratings characteristics to support those judgments, but also think about what our quality assurance and quality control processes look like in this future model as we implement that, to make sure that those are robust and that we can ensure that we're making the right judgments.
Thanks, Ro, and thanks everyone for your discussion on the comments coming through. Before I pass to Tolly to close the session, we've seen quite a few comments coming through around piloting and how to get involved in that. We're still finalising our plans and how that's going to work and how that's going to look in practice. But please do look out for further communications that we'll be sending out on that. And thank you all for your very helpful feedback, and to the panel for the discussion. I'll now pass to Tolly to close.
All right, thank you, Laura. The slide says closing remarks, reflections, next steps. Excuse me. My immediate reflection is sort of amazement and gratitude for 1,000 people spending 90 minutes of their time engaging with us. So that's an awful lot of time and experience and informed comment, and we are really grateful for that. So thank you for taking that time. Next slide, please. I'll just reiterate the next steps, and you have in fact seen this slide before. It was in the deck that Chris talked about, but one woman's repetition is another's reinforcement, so I'm never ashamed to repeat. We are still in the process of the online feedback survey, so we welcome not only what you've given us today, but anything else that colleagues, both internal and external, our stakeholders, want to give us. 5 weeks and 2 days before we close, I think, so please keep it coming. During June, we have still got several more engagement events, and particularly important will be our user voice focus groups, sector specific. And I think, you know, we put that in the second Slido section. What do you think about how we're getting feedback from experts by experience and user voice? That's both in context of what we CQC are doing, but also how our inspection will apply to providers. What should we be looking for with providers? And we will also have 4 online sector specific events with national stakeholders and providers. And we do want to keep that dialogue going. As we mentioned earlier, internally, we're looking at our new systems to support the whole regulatory process end to end. Colleagues on the call who are CQC people, you know how frustrating regulatory platform has been. Provider colleagues on the call, you know how difficult the provider portal has been at times as well. All of that will be improved and rebuilt. And the technology has to support the actual process end to end. And we've talked about our piloting. And when we talk about co-design here, what we genuinely mean is learning from our staff who use these systems. You know, it has to work for them. They don't have to be adapting to a system that's given to them. They have to influence what this system looks like so it works for them. And part of that will be our ongoing testing. And thank you all for your feedback around the piloting and so on. I think we are pretty planned on what we're doing around that, but you know, there will be more pilots in the future. So we really appreciate that feedback from stakeholders as we continue to test and strengthen all our processes, including registration. And then when we're ready, we will properly implement these new assessment frameworks, but plenty more engagement between now and then, and plenty of opportunity for stakeholders to feedback to us. One thing I have seen since coming into CQC, you know, in the last 8 months, and I've been really impressed by, is that CQC really takes seriously the feedback it receives. So, you know, no lip service to it. Every comment that's put in, everything that's sent to us is read, is considered, is categorized with other comments of those themes. So all of you have taken that time today, none of it's wasted. Last slide, please. So just to reiterate, we're ongoing till the 12th of June, 5 weeks and 2 days. Nobody's corrected me, so I must have counted the weeks right. And the link will take you through to where that feedback can be given. And of course, we've got the events we've talked about. 2 more sets of thank yous to all our comms and engagement and policy colleagues who put this together. I shouldn't marvel that the technologies work, but it's a sign of my age that I am marveling the technologies work. Thank you so much for all your effort on that and getting it running well today and capturing all the feedback. You know, really appreciate that, all of you, and of course all the work you've done on that. But most of all, to the 1,000 people who gave up 90 minutes plus of your lives to listen to us and to engage so enthusiastically in the chat. We really, really appreciate it. We so want to get this right, and we can only do it with your support and with your feedback. So thank you for taking that time, and we look forward to keeping engaging with you and perhaps meeting some of you at some events or seeing you again online. Thank you.